So I think to do it, I'd be doing 20 or 30 before you even start. I was going to say we do have a protocol somewhere on how we've done it, because we've done it joint with London before. I can't find it at the moment, but I've got the person who will know where it is away, and I'll send it to our SOP to you for that. But providing it's straightforward, it doesn't matter. So legs straight, 180 degrees, usually the person bent back. The particular angle doesn't especially matter, but providing it's I presume it will be the same couch or whatever when you're doing the study, so providing it's the same, it doesn't matter. The joint, where you put the muscle, is different in a couple of different studies. If you read them, probably doesn't matter. The London group have used anterior iliac crest as a point down to the knee. We used greater trochanter because we found that there were people too fat, our population were too fat to feel anterior iliac spine, so we've taken a pragmatic approach. So first thing you want to do is measure the leg, which we've taken as greater trochanter point. Sorry,
that's okay.
Prod and probe. So easier on someone who's a bit thinner, but greater trochanter point, bony prominence, and point of knee joint there. Measure that, and you can. We've taken a halfway point of that, so taking the point there, and get that 43 centimetres. So we half that, which would be anyone? 21 points. Yeah, so 21 centimetres would be fine. It doesn't have to be, providing it's the same every time. And this is the most important thing about ultrasound. I think one drawback to it is about longitudinal measures, because I think it is quite easy to alter your change in an individual. So cross-sectional work is really easy to do. So our recent study with cross-sectional stuff is easy because you get a one-off measurement. It's changing secondary to intervention. There's a noisy signal within it, so I think it can be difficult to do. So you need to think of, we talked about ways of marking, making sure the mark was on the same spot.
No, we could always tattoo people, couldn't we?
Yeah, well,
I don't mind learning.
Ethics
No, we didn't put that in the ethics approval, but I guess a permanent marker for 5 days.
Yeah, the permanent marker was for 5 days, but it's the longer time points. We've talked about it. So when I've been up to Loughborough, they use a method of videoing their ultrasound and using set distance from an ultrasound landmark. That's not viable unless you've got sort of 3D time dependent ultrasound. Other people, I think we talked about, use tracing paper for marking landmarks, so things like moles or marks which don't move, you could use. Anyway, so if we take 21 centimetres, you then move it to the superior aspect, take 21 centimetres from the top of the knee, directly at the top, we'll mark it off. And for video purposes, I would clearly spend a lot more time doing this if this was a patient, but I'm aware that this is easy to do. So we go up 21 centimetres, mark a point. We found that with 21 centimetres, with halfway, we could capture the whole muscle with every scan. Some of the other groups have used 3/5 of the way up. Part of the issue with that is that you don't always capture the muscle at the full group. No one you scan will have muscles as big as this. So this is the extreme. So there. So you beat frail old people in time. So it's a big issue because you have to be able to capture the whole part of the muscle on one image. If you don't, splicing it together just doesn't work as well. I know some groups do that, but it doesn't work as well. the idea is to get, so we've done it so you get 3 scans which have an area within 10% of each other. So that may take more than 3 scans, but 3 scans that show similar images. And just to try and show you how it works, see if I can. So you can have a look at the image here. Sorry, you don't get to see
No,
it.
that's okay, that's fine.
You can see. So you want to learn to do it the same way round, just so you familiarise yourself. So make sure the dots. Anyone who does ultrasound knows that the dot and that is one particular side. So when you're doing it, just learn so it's the same side every time. Doesn't matter which side it is. Then you directly apply it. What you want to do is apply as little pressure as possible to not affect it. So if you push harder, you can see the muscle deform. So what you're wanting to do is get a good connection with as little pressure as possible. And it's very important to be perpendicular. Any kinds of change in angle, you will see changes the size. So this is just where practice comes in, doing it lots and lots. Because I've never done it on this machine before, I need to sort out. So what you need to try and do is sort out an agreed depth reading, so it's always at the same measure. So that's not bad, is it? For an ultrasound, we only measure rec fem. You'll never get the whole quadriceps in, so just rectus femoris as the measure. So if we just take it here, just as so here's a shot. I don't know if you want to see it. Have a look. Anatomy is easy. So that's the femur there. So pointing down, femur there. That's your subcutaneous skin, subcutaneous fat. That there is rectus femoris. Thinking about my anatomy, that's probably vastus lateralis there, vastus medialis there. Rec fem's a nice easy bit to do around, so all we want to do for a cross-section area is measure around there, and you can get a good idea. Simple. When you get someone who's muscle-wasted, frail, not very much muscle, lots of infiltrated fat, you might not get quite as nice a picture, which is just why you need to practice. So for cross-sectional area, it's easy. You just measure the area around. Other things that you could measure would be quadriceps thickness, which is probably quicker. I think is a perfectly valid marker which you would use your calipers on from top of rec fem to the top of femur, straight vertically down. So quadriceps thickness might be a quick and easy measure to do as well. Now, I'm just down on this machine. To get to area, you press calipers, and then on page 2 press manual. And what you do, having never done it on this machine, is literally trace round it. So pick your point. Trace round the muscle. Like that. So press set. Yep. Press set. And we get a rec fem area here measuring 15.1 centimetres. So the average when we did it in our COPD population was, in the wasted people who come to the admission, is 4.8. In our stable COPD population, I think it's about 8 or 9. So that's a big muscle, but not unreasonable. And that's it. That's as easy as it is. Just to go back, if you wanted the caliper, you would pick